Hi everyone, this is part 2 of chapter 32. The last video stopped abruptly because we lost power in the School of Nursing and we were getting ready to start with rhinosinusitis, so that's where we'll begin. So a little bit about rhinosinusitis. That is the inflammation and the swelling of the mucous membranes in the sinuses, and that can often cause obstruction and be an ideal setup for bacteria. In children, the maxillary and ethmoid sinuses are the most frequently affected with rhinosinusitis. Like many conditions, it can be divided into acute and chronic. Acute would be approximately 4 weeks along with the symptoms, and chronic would be symptoms that are greater than 12 weeks or longer. Some predisposing factors for rhinosinusitis include other infections, environmental irritants such as smoking or exposure to other chemicals, allergies, if there were anatomical problems, nasal polyps, if there was a foreign body, cystic fibrosis, other immune deficiencies. The length of the symptoms are going to determine the classification of the rhinosinusitis. So the history of an acute sinusitis is different than an uncomplicated upper respiratory infection. We know with the URI that you may present with a thick yellow discharge on the 3rd or 4th day, and there may be no or just a low-grade fever. And the history of sinusitis is usually rather acute. You can have a high fever with purulent drainage. You can have the headache, bad breath. You can have fatigue. There is also often associated with double sickening, where the URI has contributed to the sinusitis, as we talked about earlier, and now you have a worsening of that condition and you're doubly sick. Criteria that's associated with a bacterial sinusitis can include facial pain, nasal congestion or fullness, discharge from the nose, difficulty smelling and tasting can be issues, and then fever. Diagnostic imaging is not needed with sinusitis, as an MRI, CT, or even plain films are likely going to be positive for inflammation in the sinuses, even if the patient has a cold. If the child is suspected to have either orbital or CNS extension of the sinusitis, then a contrast enhanced CT or MRI would be recommended. Your differential diagnoses are listed here. Management of rhinosinusitis, it's important not to overdiagnose and to treat based on overdiagnosis. If there's chronic or recurrent issues, then referring to an ENT. So if there's an upper respiratory infection lasting greater than 10 days, if there's purulent discharge, cough, or worsening fever, then those are indications to treat with antibiotics. In chapter 32 on page 807 in the second column, there are treatment considerations for treating rhinosinusitis. Drug of choice would be amoxicillin with or without potassium clavulanate as the first line of therapy. So be sure and review the dosing on page 807 in chapter 32. The use of decongestants and antihistamines, there's no controlled trials that show good evidence for using these. Topical steroids are not indicated. The data doesn't support this in kids. Even saline irrigation, the guidelines do not support this, but often saline irrigation does help clear out the congestion in the upper passages. And analgesia, of course, for fullness or pain in the head. We talked previously about these complications, but prevention is important to help manage allergy symptoms. Management of GERD, important for kids to have the flu vaccine, and then offer relief of any nasal obstruction if that is seen, so that the sinus can drain and have decreased chances of bacteria setting in. Next, we have a couple of slides on diphtheria. I'm going to let you read through these, as it is a more rare infection. And let's talk about pertussis. It's on page 809 in the book, and the other name that it can be called is the whooping cough. Pertussis is caused by a gram-negative bacillus, Bordetella pertussis, which has 6 different species. Transmission usually occurs by aerosol. Incubation can be anywhere from 7 to 10 days, with a range from 5 to 21 days. The usual source in infants is an unrecognized infection in an adult family member. There appears to be more outbreaks of pertussis despite vaccinations of adolescents and adults. Usually the source in infants, as we talked about, was a family member, but older children and adults are likely the vectors for the disease, as they have lessened symptoms and they may be mild or be more of an atypical course of treatment. The cough typically can last anywhere from 6 to 10 weeks. Clinically, the determination of stage is based on the length of time that the patient has had the pertussis. There are 3 stages. The cardiac stage, which is the first 1 to 2 weeks, the paroxysmal stage, which is 2 to 4 weeks, and the convalescent stage, which is 3 weeks to 6 months. And that information can be found on page 810 on table 32-3. Children can have apnea, and this is often associated with seizures from the hypoxemia. You can have a cough without an inspiratory whoop. They can have tachypnea, be poor feeders, and if a CBC is completed, there can be leukocytosis with marked lymphocytosis. Diagnostic studies. The gold standard is to get a culture from the nasopharynx, which can often be difficult to do. This culture is best obtained in the first 2 weeks post-cough, as that is the time when the organism will be seen in the cardiac stage. The culture can be negative if the person has been ill for greater than 2 weeks, if they've been previously vaccinated, or if antibiotics have been started. Management includes treatment with macrolides, and that information is found on page 810 for dosing for macrolides. Bactrim can be used as an alternative, and the corticosteroids and the beta-2 adrenergic meds are not supported in studies on being beneficial to help with pertussis symptoms. If you have other children in the home or those that have close contact with the child that has pertussis, that is important to treat them. It's important to review and update immunization coverages, and for student and staffs in schools to be aware of the child that has pertussis, and then close monitoring of respiratory symptoms for up to 21 days after last contact with an infected individual. Some complications may be apnea, secondary bacterial pneumonia, seizures, encephalopathy, bleeding noses, syncope, sleep issues. Prevention is important. There are some thoughts on cocooning to protect the infant from contact, and that means limiting only certain individuals to be around infants to help prevent the contact with pertussis. And then requiring adults that are around the child to have received the vaccination, including caregivers, grandparents, mothers, fathers who may not have been immunized. And then it's important to follow the CDC guidelines for vaccines. Next, let's talk about recurrent epistaxis, which we know are nosebleeds. It's very common in children, and even higher percentages for families that live in dry climates, especially during the winter when heat is typically running. The cause is typically benign but can be related to some mechanical trauma. Is usually self-limiting. There can be concerns with some coagulopathies, allergies, neoplasms, polyps, chronic rhinitis, if there's a URI, if there is a foreign body. And if you are finding more nosebleeds in adolescents, then it's important to consider recreational drug use. On your clinical findings, it's important to get a good history. Has there been any recent nasal trauma, any nose picking, any history of allergies or recent URI? Has there been unexpected bruising or bleeding from other sites? Is there a history of frequent nose bleeding? And has there been any tarry stools, which may indicate swallowing of blood? On physical exam, you're going to need to get a good visualization of the NURS, and you're looking for clots, masses. Is there a foreign body, any polyps, any raw areas, dry mucosa? You need to assess for allergy symptoms. Do they have the typical shiners, the Denny Morgan lines, any bale or boggy mucosa? Diagnostic studies would include a hematocrit if there are concerns for a severe nosebleed or chronic nosebleeds, and then if their history indicates that there could be some coagulopathies, then with the CBC make sure that there is a platelet count, a PT, and a PTT. Management of nosebleeds means encouraging your patient to sit upright, lean forward to avoid swallowing any blood, applying direct pressure to the nasal ala, packing or vasoconstrictive drugs to help stop the bleeding, bedside humidifier to help the mucosas to stay moist, topical antibiotics to scabbed areas. A silver nitrate stick may be needed to cauterize an exposed vessel. If the bleeding is persistent, then a referral to an ENT, and treating underlying causes if those are established. Prevention is important with instructions on good nasal hygiene. What also goes along with issues with the nose could be a nasal foreign body, and it's important to get a good history. Has there been any persistent or recurrent purulent drainage on one side of the nose? Is there a foul odor, nosebleeds, obstruction, or mouth breathing? It's important to question about these symptoms that we talked in clinical findings, but also you need to ask children about any foreign bodies. Often a young child is going to deny inserting anything into their nose. Differential diagnoses may include polyps, rhinitis, adenoiditis, rhinosinusitis, and nasal tumors. Management includes detecting what might be in the nose or if there is a cause to help establish diagnosis. Depending on if there is something in the nose, removal will be based on location, what it is made out of, whether it's something plastic or it's a piece of cereal, the skill of the person that's trying to take it out, and the cooperation of the child. And a referral may need to be made if it's difficult or dangerous in nature to remove. Next, we're going to talk about some extrathoracic airway disorders. And the first one that we're going to talk about is croup. And we know that croup is an acute inflammatory disease of the larynx, the trachea, and the bronchi. You have that brassy cough. There can be some stridor, some hoarseness, some respiratory distress. It's often viral in nature. What is seen is going to be dependent on the infectious agent that's caused the croup and the extent of the airway involvement. And your history may include some of the following: an upper respiratory infection that was acute in onset and with a hoarse barking cough. They may have mild to severe laryngeal obstruction. There may be some stridor. Symptoms may be worse at night. They may or may not have a sore throat, and the duration is typically 3 to 5 days for a viral croup. On physical exam, you may find that there's slight shortness of air, tachypnea, retractions, the barky cough. You may notice some stridor. There could be anywhere from low-grade to high-grade fever. The epiglottis may appear normal. There could be substernal chest wall retractions. The child may have prolonged inspiration, and if there's lower airway involvement, you may notice wheezing and rales. Croup is typically made by clinical findings. If radiology is performed, there is often noting a subglottic narrowing on the x-rays. Some differential diagnoses include acute epiglottitis, acute spasmodic croup, a foreign body, a retropharyngeal abscess, and bacterial tracheitis. Management includes a humidified air, using nebulized epinephrine. We know that the steroids can decrease inflammation and cell damage. Decadron has been found to be beneficial in croup as it reduces the inflammatory edema and also prevents destruction of the epithelium. Cough and cold medicines have not been indicated with this condition. If you're concerned that a bronchospasm is occurring, a bronchodilator may be beneficial. oxygen if SATs are less than 92%. And for severe croup, a helium-oxygen mixture known as Heliox can be used. Some indications for hospitalization are elevated respiratory rates in the 70 to 90 range if the child is in distress, a temp greater than 102.2. The use of racemic epinephrine is used in conjunction with corticosteroids to help limit any rebound swelling, and then of course using hydration and IV fluids. Some complications can include stridor, hypoxia, weakness, and unfortunately death. Let's talk next on epiglottitis. It's inflammation of the epiglottis caused by the H flu type B, and usually happens in the from 1 to 5-year-olds. The disease is 4 to 10 times higher in the Navajo Native Americans and the Alaskan Natives. So if you have populations that are in that group setting, it's important to be aware of that. Clinically, there's an abrupt onset of fever, severe sore throat, dyspnea, inspiratory distress without stridor, and a lot of drooling. And the drooling coming from the swelling in the throat. On physical exam, as we talked about the drooling, the aphonia, which is the muffled voice, high fever. There can be rapidly progressing respiratory obstruction, severe retractions. The child can have hyperextension of the neck, trying to help air to get in. Diagnostic studies include blood cultures. And with these kids, it's very important to make sure that someone is present that is able to intubate, as the condition can deteriorate very quickly. Management includes, is considered an acute otolaryngology, I can't pronounce it today, but you know what I'm trying to say, emergency. It's important to establish your airway, start antibiotics, and administer oxygen and respiratory support. Complications that may be had might be systemic spread of the organism, and then prevention is very important, and that is achieved with immunizations against the Hib. With the Hib vaccine. So that's the end of section 2, and section 3 will be following with intrathoracic airway disorders. Thank you.